Differential diagnosis of wide QRS tachycardias. Introduction. In this article, the authors discuss the differential diagnostic methods used in clinical practice to identify types of wide QRS tachycardias, QRS duration greater than 120 milliseconds. A correct diagnosis is critical to management, as misdiagnosis and the administration of drugs usually utilized for supraventricular tachycardia can be harmful for patients with ventricular tachycardia. The term narrow QRS tachycardia indicates individuals with a QRS duration less than or equal to 120 milliseconds, while wide QRS tachycardia refers to tachycardia with a QRS duration greater than 120 milliseconds. Narrow QRS complexes are due to rapid activation of the ventricles via the His-Purkinje system, suggesting that the origin of the arrhythmia is above or within the His bundle. However, early activation of the His bundle can also occur in high septal ventricular tachycardia, VT, resulting in relatively narrow QRS complexes of 110 to 140 milliseconds. Wide QRS tachycardias can be VT, 80%. Supraventricular tachycardia, SVT, conducting with bundle branch block, BBB, aberration, 15%. Supraventricular tachycardia, SVT, conducting over an accessory pathway, 5%. Regular tachycardias. As a rule, the default diagnosis of a wide QRS tachycardia should be VT until proven otherwise. VT is defined as a tachycardia, rate greater than 100 beats per minute, with 3 or more consecutive beats that originate in the ventricles. Differential diagnoses. SVT with bundle branch block. This may arise due to pre-existing bundle branch block or the development of aberrancy during tachycardia, known as phase 3 block, which more commonly has a right bundle branch block, RBBB, pattern due to the longer refractory period of the right bundle branch. SVT with antegrade conduction over an accessory pathway that participates in the circuit, antidromic atrioventricular reentrant tachycardia, or is a bystander during AF, focal atrial tachycardia/flutter or atrioventricular nodal reentrant tachycardia. SVT with widening of the QRS interval induced by drugs or electrolyte disturbances. Class 1C and 1A drugs cause use-dependent slowing of conduction, and Class 3 drugs prolong refractoriness to a greater extent at the His-Purkinje tissue than in the ventricular myocardium. Both can result in atypical bundle branch block morphologies during SVT that mimic VT. Apical ventricular pacing, pacemaker-related endless loop tachycardia and artifacts can also mimic VT. Electrocardiographic differential diagnosis. If the QRS morphology is identical during sinus rhythm and tachycardia, then VT is unlikely. However, bundle branch reentrant VTS and high septal VTS exiting close to the conduction system can have similar morphologies to sinus rhythm. The presence of a contralateral bundle branch block pattern in sinus rhythm is more indicative of VT. Atrioventricular dissociation. The presence of either atrioventricular dissociation or capture/fusion beats in the 12-lead ECG during tachycardia are key diagnostic features of VT. Atrioventricular dissociation may be difficult to recognize because P waves are often hidden by wide QRS and T waves during a wide QRS tachycardia. P waves are usually more prominent in inferior leads and modified chest lead placement, Lewis lead. The relation between atrial and ventricular events is 1:1 or greater, i.e. more atrial than ventricular beats, in most SVTs. Atrioventricular nodal reentrant tachycardia can be associated with 2:1 conduction, but this is rare. Although VA conduction can be found in up to 50% of patients with VT and a 1:1 relation is possible, Most VTS have a relation of less than 1 to 1, i.e. more QRS complexes than P waves. QRS duration. A QRS duration greater than 140 milliseconds with right bundle branch block or greater than 160 milliseconds with left bundle branch block, LBBB, pattern suggests VT. These criteria are not helpful for differentiating VT from SVT in specific settings, such as pre-excited SVT or when Class 1C or Class 1A antiarrhythmic drugs are administered. Table 1. Differential diagnosis of wide QRS tachycardias. Wide QRS, greater than 120 milliseconds, tachycardias. Regular. Ventricular tachycardia/flutter. Ventricular paced rhythm. Antidromic AV reentrant tachycardia. Supraventricular tachycardias with aberration/bundle branch block, pre-existing or rate-dependent during tachycardia. Atrial or junctional tachycardia with pre-excitation/bystander accessory pathway. Supraventricular tachycardia with QRS widening due to electrolyte disturbance or antiarrhythmic drugs. Irregular. AF or atrial flutter or focal atrial tachycardia with varying block conducted with aberration. Antidromic AV reentrant tachycardia due to a notoventricular/fascicular accessory pathway with variable VA conduction. Pre-excited AF. Polymorphic VT. Tours aids de points. VF. Occasionally, AF with very fast ventricular response may apparently resemble a regular narrow QRS tachycardia. Table 2. ECG criteria in the 2019 European Society of Cardiology guidelines suggest ventricular rather than supraventricular tachycardia in wide complex tachycardia. Atrioventricular dissociation. Ventricular rate greater than atrial rate. Fusion/capture beats. Different QRS morphology from that of tachycardia. Chest lead negative concordance. All precordial chest leads negative. RS in precordial leads. Absence of RS in precordial leads. RS greater than 100 milliseconds in any lead, asterisk. QRS complex in AVR. Initial R wave. Initial R or Q wave greater than 40 milliseconds. Presence of a notch of predominantly negative complex. QRS axis -90 degrees to plus or minus 180 degrees both in the presence of right and left bundle branch block morphology. R wave peak time in lead 2. R wave peak time greater than or equal to 50 milliseconds. Right bundle branch block morphology, lead V1, monophasic R, RSR, biphasic QR complex, broad R, greater than 40 milliseconds, and a double-peaked R wave with the left peak taller than the right, the so-called rabbit ear sign. Lead V6, RS ratio less than 1, RS, QS patterns. Left bundle branch block morphology lead V1, broad R wave, slurred or notched downstroke of the S wave and delayed nadir of S wave. Lead V6, Q or QS wave. Asterisk Rs equals beginning of R to deepest part of S. QRS axis. Since VT circuits, especially post-MI or in cardiomyopathies, frequently lie outside the normal His-Purkinje network, significant axis shifts are likely to occur that enable diagnosis. In SVT patients with aberrancy, the QRS axis is confined between -60 degrees and +120 degree. Extreme axis deviation, from -90 degrees 90 degrees to plus or minus 180 degree, is strongly indicative of VT in the presence of right bundle branch block and left bundle branch block. Chest lead concordance. The presence of negative chest lead concordance, i.e. when all QRS complexes in leads V1, V6 are negative, is almost diagnostic of VT, with a specificity of greater than 90%, but is only present in 20% of VTS, figure 1. Positive concordance can be indicative of VT or an antidromic tachycardia utilizing a left posterior or left lateral accessory pathway. Right bundle branch block morphology. In the V1 lead, typical right bundle branch block aberrancy has a small initial R, since in right bundle branch block the high septum is activated primarily from the left septal bundle. This means that RSR, RSR, or RR patterns are evident in lead V1. However, in VT the activation wave front progresses from the LV to the right precordial V1 lead in such a way that a prominent R wave, monophasic R, RSR, biphasic QR complex or broad R greater than 40 milliseconds, will more commonly be seen. Additionally, a double-peaked R wave, M pattern, in lead V1 favors VT if the left peak is taller than the right peak, the so-called rabbit ear sign. A taller right rabbit ear characterizes RIGHT bundle branch block aberrancy but does not exclude VT. In the V6 lead, a small amount of normal right ventricular voltage is directed away from V6. Since this is a small vector in right bundle branch block aberrancy, the RS ratio is greater than 1. In VT, all of the right and some of the left ventricular voltage is directed away from V6, leading to an RS ratio less than 1, Rs and QS patterns. A right bundle branch block morphology with an RS ratio less than 1 in V6 is seen rarely in SVT with aberrancy, mainly when the patient has a left axis deviation during sinus rhythm. Left bundle branch block morphology. In the V1 lead, the presence of broad R wave, slurred or notched downstroke of the S wave, and delayed nadir of the S wave are strong predictors of VT, for the same reasons as stated for right bundle branch block. In the V6 lead, no Q wave is present in the lateral precordial leads in true left bundle branch block. The presence of any Q or QS wave in lead V6 favors VT, indicating that the activation wave front is moving away from the left ventricular apical site. A number of algorithms have been developed to differentiate VT from SVT. The most established are the Brugada algorithm and the Verrecke algorithm, which utilizes a single AVR lead. Measurement of the R wave peak time in lead 2. Figure 1. Measurement of the R wave peak time in lead 2. Lead 2. R wave peak time greater than or equal to 50 milliseconds. No. Supraventricular tachycardia. If yes, R wave peak time greater than or equal to 50 milliseconds in lead 2, so it is ventricular tachycardia. Lead 2. 80 milliseconds. R wave peak time measured from the isoelectric line to the point of first change in polarity, was greater than 50 milliseconds, 80 milliseconds, see arrows on ECG. Figure 2, differential diagnosis of wide QRS tachycardia using the Brugada ETAL algorithm. Absence of RS in all precordial leads. Yes. VT. If no, so go to the next step. Rs interval, beginning of the R wave to the deepest part of the S wave, greater than 100 milliseconds in any precordial lead? Yes. VT. If no, so go to the next step. Atrioventricular dissociation? Yes. VT. If no, so go to the next step. Apply the following conventional criteria. Right bundle branch block morphology. V1. Monophasic R. RSR. Yes. VT. V1 or V6. Triphasic QRS. If yes, so it is SVT. Next step. Left bundle branch block morphology. V1 or V2. R greater than 30 milliseconds, or greater than 60 milliseconds to nadir S, or notched S. Yes. VT. The Rs interval, A, enlarged in, B, measures 160 milliseconds in lead V4 and 70 milliseconds in lead V6. Thus, the longest Rs interval is greater than 100 milliseconds, and diagnostic of ventricular tachycardia. Differentiating fascicular VT from SVT with bifascicular block, right bundle branch block and left anterior hemi block, is very challenging. Features that indicate SVT in this context include QRS greater than 140 milliseconds, R in V1, overall negative QRS in AVR, and RS ratio greater than 1 in V6. Figure 3, differential diagnosis of wide QRS tachycardia using the VHRS algorithm. AVR lead. Initial R wave. Yes. Ventricular tachycardia. If no, so go to the next step. Initial R or Q wave greater than 40 milliseconds. Yes. Ventricular tachycardia. If no, so go to the next step. Notch on the descending limb of a negative onset, and predominantly negative QRS. Yes. Ventricular tachycardia. If no, so go to the next step. VI/VT less than or equal to 1. Yes. Ventricular tachycardia. If no, so it is supraventricular tachycardia. ECGs, the vertical lines on the AVR lead show the onset and end of the QRS complex. Crosses indicate the first and last 40 milliseconds of the chosen QRS complex. The ventricular activation velocity ratio, VI/VT, is calculated by measuring the vertical excursion in millivolts recorded on the ECG during the initial, VI, and terminal, VT, 40 milliseconds of the QRS complex. Left, during the initial 40 milliseconds of the QRS, the impulse traveled 0.15 mV vertically, therefore, VI equals 0.15. During the terminal 40 milliseconds, the impulse traveled 0.6 mV vertically, therefore, VT equals 0.6. Thus, VI/VT less than 1 yields a diagnosis of ventricular tachycardia. Right, VI equals 0.4 and VT equals 0.2, thus, VI/VT greater than 1 suggests a diagnosis of supraventricular tachycardia. RS interval in the precordial leads. The absence of Rs complex in the precordial leads, i.e. only R and S complexes are seen on ECG, is only found in VTS, figure 2. An Rs complex is found in all SVTs and in 74% of VTS. No SVT with aberrant conduction has an interval greater than 100 milliseconds between the onset of the R wave and the deepest part of the S wave at its longest duration, irrespective of the morphology of the tachycardia. About half of VTS have an Rs interval less than or equal to 100 milliseconds, and the other half have an Rs interval greater than 100 milliseconds. The Brugada ETAL algorithm has a sensitivity and specificity of 98.7% and 96.5%, respectively. QRS complex in the AVR lead. During sinus rhythm and SVT, the wave front of depolarization moves away from the AVR lead, yielding a negative QRS complex in the AVR lead with few exceptions, for example inferior myocardial infarction. In contrast, the presence of an initial R wave, RS complex, in the AVR lead suggests VT, figure 3. The VHRS algorithm has a 91.5% overall accuracy in the diagnosis of VT. R wave peak time at lead 2 greater than or equal to 50 milliseconds. This criterion has the potential advantage that lead 2 is easy to obtain and is almost always present on ECG rhythm strips recorded in different settings, for example ECG monitoring in emergency rooms and intensive care units. In lead 2 an R wave peak time greater than or equal to 50 milliseconds, independent of whether the complex is positive or negative, has been reported to have a sensitivity of 93% and specificity of 99% for identifying VT, figure 1, but these results were not verified in the first large external application of this criterion. All criteria have limitations. Several conditions, such as bundle branch reentrant tachycardia, fascicular VT, VT with exit site close to the HIS, Purkinje system and wide QRS tachycardia occurring during antiarrhythmic drug treatment, are difficult to diagnose using the morphological criteria mentioned. This is most pronounced in VT originating from septal sites, particularly Purkinje sites and the septal outflow tract regions. Left posterior fascicular VT, the most common form of idiopathic left ventricular VT, is frequently misdiagnosed as SVT with right bundle branch block and left anterior hemiblock aberration. Differentiation between VT and antidromic AVRT is extremely difficult because the QRS morphology in antidromic AVRT is similar to that of a VT originating at the insertion of the accessory pathway in the ventricular myocardium. An algorithm has been derived for differential diagnosis based on the analysis of 267 wide QRS tachycardias, consisting of VT and antidromic AVRT. The criteria derived from this analysis were found to have a sensitivity of 75% and specificity of 100%, and the algorithm was validated in another study, but experience is still limited. Several independent studies have found that various ECG-based methods have specificities of 40 to 80% and accuracies of 75%. A similar diagnostic accuracy of 75% would be achieved effortlessly by considering every wide QRS tachycardia to be a VT because only 25 to 30% are SVTs. Emerging approaches to integrate these algorithms to provide more accurate scoring systems are being evaluated. Localization of the origin of scar-related ventricular tachycardia. Figure 4 presents the ECG morphology of idiopathic ventricular tachycardia with different sites of origin, and Figure 5 demonstrates localization of the origin of scar-related VT. Figure 4, 12-lead electrocardiogram morphology of different sites of idiopathic ventricular tachycardia origin. Outflow tract VT. Paravalvular VT. Intracavity VT. Fascicular VT. Epicardial VT. Figure 5, localization of the origin of scar-related ventricular tachycardia. A. 1 short axis location maximal QRS amplitude limb leads. B. 2 longitudinal axis location V3, V4 polarity. C. D. Steps. 1 highest voltage magnitude, lead 3 with a negative polarity. 2 adjacent lead with higher magnitude, lead AVF with a negative polarity. 3 polarity V3 and V4, both have positive polarity. Left panel, QRS axis, based algorithm showing the 17-segment model from the American Heart Association, superimposed on a representation of the QRS axis, and all the limb leads. Steps to identify the segment of origin of a ventricular arrhythmia are as follows. A. Identify the limb lead with the highest voltage, positive or negative. If in lead 1, 2, or 3, analyze the adjacent leads. The adjacent limb lead with higher voltage will determine the group of segments likely to be the site of origin. B. Identify the positivity or negativity of precordial leads V3 and V4, concordance indicates a basal or apical origin, respectively. Other combinations indicate a medial origin. Right panel, example of the application of the QRS axis, based algorithm. C. An ECG of ventricular tachycardia. D. the application of the QRS axis-based graphical algorithm. In the ECG, the lead with the highest voltage is 3. 2. Applying step 1, the segment the ventricular tachycardia originates from is one of the sections in the red circle. Analyzing voltage in the adjacent leads reveals that AVF2 has a higher voltage than AVL1 and the origin is therefore in a segment within the blue circle. Application of step 2 indicates the ventricular tachycardia has a basal origin, as leads V3 and V4 are both more positive than negative. The final segment selected by the algorithm is 4, green circle. Electrophysiology study. On certain occasions, such as tachycardias with borderline QRS duration and or in the absence of atrioventricular dissociation, an electrophysiology study is necessary for diagnosis. Irregular tachycardias. An irregular ventricular rhythm most commonly indicates AF, multifocal atrial tachycardia or focal atrial tachycardia / atrial flutter with variable atrioventricular conduction, and may occur in the context of both narrow and broad QRS complexes. When AF is associated with rapid ventricular rates, the irregularity of this ventricular response is less easily detected and can be misdiagnosed as irregular SVT. If the atrial rate exceeds the ventricular rate, then atrial flutter or atrial tachycardia, focal or multifocal, is usually present. Polymorphic VT and, rarely, monomorphic VT may also be irregular. Occasionally, a junctional, non-reentrant tachycardia may have a variable rate. The differential diagnosis of an irregular wide QRS tachycardia is either pre-excited AF, or polymorphic VT, or atrial arrhythmia with variable block in the context of aberrancy. Pre-excited AF manifests as irregularity, varying QRS morphology and rapid ventricular rate owing to the short RP of the accessory pathway. The changing QRS morphology results from varying degrees of fusion due to activation over both the accessory pathway and the atrioventricular node, or over two accessory pathways, which also results in variation in the width of the delta wave. The ventricular rate tends to be higher than in those with non-pre-excited AF. Thank you for watching.